Mechanical ventilation for the non-intensivist. Theory. In this lecture, we'll overview the goals of mechanical ventilation, consider how breathing works, and then compare that to how mechanical ventilation works. We'll also briefly discuss the side effects of mechanical ventilation. The goals of mechanical ventilation are first, to do no harm, and secondly, to ensure adequate oxygenation and CO2 clearance. Mechanical ventilation is a potentially life-saving device, but it can also do great harm to the lungs, to the diaphragm, and to the circulation. And so it must be used with great care. And these potential harms must be constantly borne in mind when applying mechanical ventilator settings to achieve adequate oxygenation and CO2 clearance. The basic goal of breathing is to ensure adequate gas exchange. Oxygen diffuses out of the alveolus across the alveolar membrane and into the pulmonary circulation, while CO2 diffuses out of the pulmonary circulation across the alveolar membrane and into the alveolus. In order to ensure appropriate partial pressures of these gases in the alveolus to drive diffusion, breathing works by the bulk flow of gas in and out of the lung, and this achieves the gradients that drive diffusion of gas in the appropriate direction. I find it helpful to consider the various lung volumes while setting the mechanical ventilator because the tidal volume is distributed over a small proportion of the total range of potential lung volume. The ventilator is set to deliver a specific tidal volume, and depending on how positive end expiratory pressure is set, the relative end expiratory lung volume may be higher or lower. Disease states also affect the lung volume. In patients with acute pulmonary insults, the maximum lung volume available for ventilation may be reduced, or functional residual capacity may be increased if there is evidence of acute increase in expiratory resistance to airflow. When the total volume of lung available for ventilation is reduced, then the tidal volume takes up a greater proportion of the total lung volume available for ventilation, and this increases stress and strain within the lung. This is the basis for understanding how mechanical ventilation and breathing can actually injure the lung in the context of acute lung injury. During each mechanical breath, the lung is inflated by pressure and flow delivered by the ventilator or by the respiratory muscles. Because the lung is a complex anatomical structure, it has very specific mechanical characteristics that are shown here in this pressure volume curve. The inspiratory limb is shown with the open circles, and the expiratory limb is shown with the closed black circles. During inspiration, initially as pressure rises, there is very little increase in volume, and this is because at low lung volumes, the small airways and alveoli are collapsed and require a certain pressure to be reopened. As applied pressure continues to increase above the airway opening pressure, the lung inflates more rapidly and more easily. This is the most compliant portion of the pressure volume curve. As lung volume increases to high levels, the elastic properties of the lung begin to stiffen the lung as it is overdistended, and so compliance is reduced. Ideally, we want to apply sufficient end expiratory pressure to keep the lung volume above the pressure required to open the lung, while minimizing the amount of stretch that we apply to the lung by avoiding overdistension. On the expiratory limb, as gas flows out of the lung, you can see that lung volume remains relatively preserved as pressure decreases and falls relatively later as pressure returns towards zero. This difference in pressure volume curves is referred to as hysteresis. It's the consequence of the action of surfactant, which reduces surface tension within the alveoli and helps to reduce lung collapse. It's important to appreciate that patients vary widely in the level of lung recruitment that can be achieved by applying high pressures and volumes temporarily. Some patients will have a very large gain in lung volume, and in these patients, using a higher airway pressure is probably beneficial, while in others, the difference between the inspiratory and expiratory limbs of the pressure volume curve is very small. These patients have less recruitability and probably benefit less from the use of higher airway pressures. Another important aspect of breathing is controlled by the brainstem respiratory controller. The respiratory controller is sensitive to various stimuli, especially chemoreceptive stimuli like carbon dioxide. The controller consists of a complex network of neurons residing in various parts of the brainstem, but their basic function is to generate respiratory rhythm. This respiratory rhythm can be described using three different terms: the trigger, what starts the breath; the target, how deep of a breath you take; and the limit, how long you breathe in for. And these various parameters will vary according to the amount and type of stimuli that are entering the brainstem. Thinking about normal breathing in this way helps us to understand the different modes of mechanical ventilation. So now we turn to how mechanical ventilation works. Basically, the ventilator has two jobs: to clear CO2 and to oxygenate. To clear CO2, we need adequate minute ventilation, and the minute ventilation that you achieve will depend on the trigger, the target, and the limit. The oxygenation that you achieve will depend on the fraction of inspired oxygen and the positive end expiratory pressure, which is used to keep the lung open. So first, getting an adequate minute ventilation. The trigger determines the respiratory rate, and the ventilator can be triggered to breathe in two ways. First, by time. If the respiratory therapist or physician sets the ventilator to have a respiratory rate of 20, this means that the ventilator will be triggered to deliver an inspiratory volume or pressure every 3 seconds. Essentially, the trigger is based on time. The ventilator can also be triggered by the patient because of fluctuations of flow or pressure within the ventilator circuit that the ventilator senses as patient inspiratory efforts. Certain modes of mechanical ventilation will sense the patient based on diaphragm electrical activity, but the basic modes of ventilation rely on flow or pressure. In some, the triggering mechanism determines how often a breath is delivered, or the respiratory rate. Once the ventilator is triggered, we need to get an adequate tidal volume. And the tidal volume is determined by the target, how deep of a breath is delivered, and the limit, when the breath ends. Each of the different basic modes of mechanical ventilation are defined in terms of the target and the limit. So with volume control, the target is the set flow rate, say 40 liters per minute, and the limit is the tidal volume. So the set flow rate of 40 liters per minute is delivered until a tidal volume of 400 cc's is delivered. In pressure-controlled ventilation, the target is pressure, that is, how much the pressure increases to drive flow of gas into the lung, and the limit is time. That pressure will be applied for the duration of time set on the ventilator. In pressure support, the target is again pressure, but this time the limit is actually flow. Initially, when pressure is applied by the ventilator, inspiratory flow rapidly rises, and then as the lung is inflated up the pressure volume curve, flow begins to drop as the lung stiffens. In pressure support, when the flow drops to a set proportion of peak inspiratory flow, that's how the ventilator knows to stop the breath. And this gives the patient a little bit more control of the duration of the breath and is therefore more synchronous. this is how the different modes of mechanical ventilation achieve a given tidal volume, the target and the limit. Here's an example of pressure, flow, and volume tracings from two different modes of mechanical ventilation. On the left, we have pressure-controlled ventilation. You can see that when the breath is triggered, the pressure rapidly rises and then stays steady for a set duration of time. When the limit on the breath is reached, the pressure drops back down to baseline. While the pressure is being delivered, you can see that flow rapidly rises and then progressively decays, and tidal volume rises progressively, but stabilizes and does not continue to rise as inspiratory flow drops off. By comparison, volume control is shown on the right. In this mode of mechanical ventilation, the target is flow, and so you can see the flow waveform increases from baseline to a constant steady level before cycling off into expiration. And the limit defining expiration is tidal volume. So you can see that with the constant application of flow, tidal volume progressively rises until the peak is reached. And at that set inspired tidal volume, the ventilator knows it's time to stop delivering inspiratory flow and cycle into exhalation. You can see here that the pressure progressively rises. The other major task of the mechanical ventilator is to improve and maintain oxygenation. In order to understand how it does this, it's important to understand why mechanically ventilated patients develop hypoxemia. This occurs for a variety of reasons, but the most important mechanism is shunt because of collapsed, non-ventilated alveoli, as represented in the CT scan image shown in the bottom right corner. You can see here two different regions of lung, one open and available for ventilation, and the other collapsed and closed to ventilation. And because blood is flowing through both regions, the patient becomes hypoxemic because some of the blood perfusing the lung is not ventilated by fresh gas. So in order to improve oxygenation, the ventilator can do two things. First of all, it can deliver a very high fraction of inspired oxygen to alveoli that are ventilated to increase the diffusion of oxygen into the circulation. But the benefit of this is limited because oxygen carrying capacity is determined by hemoglobin concentration, which can be saturated, and further increases in alveolar partial pressure of oxygen don't increase oxygen content of the blood once hemoglobin is saturated. So the other way in which the ventilator can improve oxygenation is by applying positive end expiratory pressure to minimize the amount of lung collapse. This is called lung recruitment. And the goal of setting positive end expiratory pressure is to minimize lung collapse in order to minimize shunt and improve oxygenation of blood. An important caveat is that increasing positive end expiratory pressure pressurizes the whole lung and at high levels can potentially injure the lung or increase the risk of lung injury as well as injury to circulatory function. So the side effects of increasing positive end expiratory pressure must be constantly borne in mind. And it's to this subject that we'll now briefly turn. There are three major side effects of mechanical ventilation that need to be considered. First, hemodynamic effects of positive pressure. Secondly, ventilator-induced lung injury. And thirdly, the potential deleterious effects of mechanical ventilation on the respiratory muscles. First, let's briefly consider the hemodynamic effects. The heart and the lung are situated side by side within the chest wall, and consequently, pressurizing the lung with mechanical ventilation can exert pressure on the heart by increasing pleural pressure. This can have significant effects on the function of the left heart and the right heart. In general, pressurizing the lung and the chest impairs right heart function and augments left heart function. It impairs right heart function because the high pleural pressure reduces the gradient for the drainage of venous blood back toward the heart. It pressurizes the pulmonary circulation, resulting in an increase in afterload for the right heart. So positive pressure ventilation decreases right heart preload and increases right heart afterload. And this can have serious hemodynamic consequences, particularly when right ventricular function is impaired. So careful attention must be paid to hemodynamics, volume status, and right heart function in mechanically ventilated patients. On the other hand, positive pressure tends to augment or support left ventricular function. This is because positive pressure actually reduces the afterload on the left heart. The afterload on the left heart is a function of the tension on the wall of the myocardium, which in turn depends in part on the pressure gradient across the wall of the myocardium. When patients are in respiratory distress and breathing vigorously, there can be very large negative pleural pressure swings, and this actually increases the gradient across the wall of the myocardium substantially, requiring much greater forces to drive blood out of the left ventricle into the circulation. When you place a patient on positive pressure ventilation, the pleural pressure is now positive, and the pressure gradient across the myocardium is greatly reduced. This reduces afterload and improves LV performance substantially. However, LV dysfunction can become an important problem when weaning mechanical ventilation because the progressive reduction in positive pressure and the increased respiratory muscle action lowers intrapleural pressure and thereby increases afterload. So you can think of weaning mechanical ventilation as a kind of cardiac stress test. The most common reason patients encounter difficulties weaning from mechanical ventilation is because of acute left heart failure with weaning-induced pulmonary edema. This problem can be avoided by managing volume status effectively and by paying attention to management of systemic afterload in patients with known LV dysfunction. Because of these heart-lung interactions, the period of time during which a patient is intubated can be quite precarious. These patients are often in respiratory distress and volume deplete because of their underlying critical illness. So the gradient for venous return is reduced to begin with. However, hemodynamics are maintained because of the large negative swings in pleural pressure that draw blood back towards the heart. When you intubate such a patient, you sedate them, and this reduces sympathetic output, resulting in systemic vasodilation and a substantial reduction in the gradient for venous return. At the same time, you're applying positive pressure, which can further reduce the gradient for venous return and potentially impair right heart function. So very close attention must be paid to monitoring hemodynamics and volume status as you're preparing to intubate a patient. At the same time, some of the drugs that are used for intubation, such as propofol, can have significant myocardial depressant effects, further increasing the risk of hemodynamic instability. These hemodynamic consequences of positive pressure ventilation must be borne in mind when intubating and setting the mechanical ventilator. The second major harm of mechanical ventilation that must be borne in mind is the risk of ventilator-induced lung injury. When the ventilator applies excessive pressure and volume to the lung, it can overstretch regions of the lung, resulting in potentially serious inflammation and injury. This harm can occur at low lung volumes because much of the lung is collapsed and the volume of lung is available for ventilation is markedly reduced, or it can occur at very high lung volumes, as shown on the right, with substantial hemorrhagic necrosis as a consequence of excess ventilation. The basic mechanism of ventilator-induced lung injury is over. For this reason, it's been shown that reducing tidal volume and ensuring that airway pressures are not excessive is actually associated with an improvement in mortality in patients with acute respiratory distress syndrome. So avoiding the risk of ventilator-induced lung injury can actually improve the patient's outcome substantially. In general, for mechanically ventilated patients, we recommend tidal volumes of 6 to 8 cc's per kilo predicted body weight. Tidal volume is normalized to predicted body weight because this correlates to the size of the lung available for ventilation. In patients without acute respiratory distress syndrome or who are recovering in the weaning phase, larger tidal volumes may sometimes be tolerated. At the same time, plateau pressure, the maximum pressure applied to distend the lung from tidal volume, should be closely monitored and maintained under 30 centimeters of water. The gradient between plateau pressure and positive end expiratory pressure, referred to as the driving pressure, should be minimized as much as possible, and the risk of ventilator-induced lung injury when driving pressure is above 15 to 20 centimeters of water is probably high. A third important form of ventilation iatrogenesis is the phenomenon of ventilator-induced diaphragm dysfunction. There are several different mechanisms by which the ventilator may cause acute diaphragm weakness. Perhaps the most important is acute disuse atrophy. You can see in the figure on the left that patients in the case column, that is patients who were brain dead organ donors and who had no respiratory muscle activity for just a short period of time, have much smaller myofibril cross-sectional area in comparison to control subjects. This is the acute disuse atrophy that can develop from the cessation of respiratory muscle effort. The figure on the right shows the trajectory of diaphragm thickness over time during mechanical ventilation in different subgroups of patients. The patients with no significant change over time, the green line, were approximately 45% of patients, and another 45% of patients exhibited a marked decrease in diaphragm thickness over time. So acute disuse atrophy of the diaphragm seems to be very common. Some patients may also be vulnerable to load-induced injury from excessive respiratory effort, and these might be represented by the patients in the upper blue line, although this hypothesis remains to be substantiated. Ventilator-induced diaphragm dysfunction is an important problem because the diaphragm, the primary muscle of inspiration, determines the patient's ability to be liberated from the ventilator. By causing acute diaphragm dysfunction, mechanical ventilation can actually perpetuate ventilator dependence. Acute diaphragm weakness is very common in mechanically ventilated patients and is an important cause of morbidity and mortality. The important point for clinicians to remember is that we should pay close attention to whether or not the patient's breathing, and in order to try and minimize the period of time during which the respiratory muscles are inactive, and to activate them at the earliest opportunity to avoid acute disuse atrophy of the diaphragm. The important message is that mechanical ventilation is not a benign intervention. It's a life-saving device that dramatically changes morbidity and mortality in patients with acute critical illness, but it must be used carefully and judiciously in order to optimize outcomes for patients. In summary, in this lecture, we covered the basics of respiratory physiology and breathing. We introduced the basic concepts of how mechanical ventilation works in terms of modes of mechanical ventilation and in terms of oxygenation. And we identified 3 different potential serious harms resulting from misapplication of the ventilator. To recap, the goals of ventilation are first to do no harm, and then to maintain adequate CO2 clearance and acid-base homeostasis, inadequate oxygenation and oxygen delivery.